Hi, this is Dr. Nina, and today we are discussing pulmonology. This is the patient 65 years old smoker with inspiratory dyspnea while walking 500 meters, episodic dry cough, weakness, and tiredness. He is ill for 3 months and has also cardiovascular disease, arterial hypertension. Physical examination includes mild clubbing, P2 accent, and basal crackles, and mild erythrocytosis and elevation of hemoglobin. The clubbing is specific changes in chronic hypoxia, sometimes the first sign of ELDs. Crackles, specific sign of the ELD also. Let's listen to them. Interstitial lung disease, it is a heterogeneous group of disorders characterized by fibrosis of scarring of the lungs. Here there is the classification and the updated classification 2018 with update of the autoimmune LDs. Idiopathic pulmonary fibrosis is specific form of the chronic progressive fibrosing interstitial pneumonia of unknown cause limited to lungs with the pattern of usual interstitial pneumonia with lung scarring, and also the UIP pattern can be as also a feature of autoimmune diseases, but in this case it is called UIP but not IPF. The diagnostic algorithm for ELDs include first of all to suspect, then to exclude other diagnoses, to diagnose the specific entity, and then to discuss it with the multidisciplinary team. In our patient, we see the classical features of IPF by the peripheral honeycombing and traction bronchoectasis. The peripheral honeycombing, it is shown here. It is a result of the fibrosis, and traction bronchoectasis results from the pulling of the fibrotic tissue of the bronchi and formation of bronchoectasis due to this. Initial changes in IPF may be limited to reticulation, minor changes, but ground glass opacity it is exclusive for IPF because ground glass opacity it is inflammatory but not fibrotic. The spirogram reveals the decrease both FVC and FEV1, but the restrictive changes in the restrictive pattern, the vital capacity is decreased more than FEV1. That's why the ratio is more than 1. Also, the diffusion is decreased. The biopsy predominantly is not needed. If there are specific CT changes in probable IPF, it can be done, but decision is individual. Not recommended usually for connective tissue disorders related. Why it happens? First of all, the telomere shortening and precursor cell senescence predominantly by epithelial dysfunction with senescence associated secretory phenotype. More concrete, the abnormal activation of epithelial cells with profibrotic cytokine secretion, proliferation and differentiation of fibroblasts to myofibroblasts with secretion of the extracellular matrix and its deposition, dysfunction and exhaustion of the stem cells. The treatment approaches are targeted to fibrosis and include antifibrotics, pirfenidone, and nintedanib. Some other drugs are in clinical trials. The new approaches to diagnosis include the genotype also, and new approaches to treatment include the specific algorithm for treatment of the autoimmune rheumatic diseases related TLD and personalized biomarker specific treatment for IPF. So that's all. Thanks a lot. We'll meet with the other disease.